we don't get you guys out on time for lunch. We have been talking about alcohol, and we're going to continue to do that. We've spent the last few weeks looking at clinical screening and interventions that we can provide, non-pharmacological interventions that we can provide. And so today we're going to start looking into setting the course for looking at medication treatment for different aspects of alcohol addiction. So we're going to kind of set up, a little bit of discussion about what alcohol intoxication withdrawal are, and then that will lead us into talking about medication options for treatment of alcohol withdrawal over the next few weeks. I don't have any disclosures. Next slide, please. We're going to just briefly look at what an alcohol hangover looks like. I won't spend a lot of time on that because it's not all that clinically relevant in terms of treatment wise. And then we'll look at what alcohol intoxication looks like. Generally, in severe cases, that's going to be an emergency room treatment if needed. So again, won't spend a lot of time on that, but we're going to really focus on the clinical presentation of alcohol withdrawal as a setup for how to manage that medically over the next few weeks. So alcohol hangover, I think most of us have either had this or seen people who've had it or seen people on TV who've had it. It's really just a vague constellation of this unpleasant feeling, both physically and mentally, and it occurs generally after heavy bouts of alcohol intake. For many people, this is what's occurring when they're more binge drinking and they're not used to binge drinking. It consists of headache is the most common symptom, followed by this general malaise and fatigue feeling, but can also be accompanied by GI symptoms like diarrhea and nausea, difficulty concentrating, and then anxiety and sensitivity to sounds, or light, and sound. We don't completely understand the pathophysiology of it. Maybe it's due to buildup of one of the alcohol metabolites that we talked about in the pharmacology of alcohol, acetaldehyde, but we don't know that 100%. And some people will even say that it may be secondary to, there may be a role of different cogeners that are present in different types of alcohol, because dark liquors tend to lead to hangover more than clear liquors, but you can have a hangover with any liquor. So we don't really understand fully. And there's not a great treatment for alcohol hangover, and there's those home remedies you can buy from the store. People take aspirin. People do quite a bit of things. And then Dr. Blue has let us know that alcohol use disorder, many individuals, alcohol use disorder refer to a hangover that is synonymous with withdrawal. So they think they're having a hangover when they're actually having withdrawal. So then that is correct. And so people will be, because they have some similar symptoms, particularly early on with that anxiety and headache and nausea that people will get with withdrawal as well. So thank you, doctor. So before we start talking about intoxication withdrawal, I just want to do a really brief, basic summary of some of the basic alcohol physiology or the neurotransmitter physiology in the brain. And when we're talking about that, we're gonna focus on two main neurotransmitters. We have something in our brain called gamma aminobutyric acid, or GABA. Everyone just says GABA because it's easier to say. And GABA is our most common inhibitory neurotransmitter in our brain. By inhibitory, it means we're shutting things off. We're slowing activity down in the brain. The other receptor we're going to look at or focus on a lot when it comes to intoxication and withdrawal is one called glutamate. And glutamate is our most abundant excitatory neurotransmitter in the brain, meaning that it excites the brain or potentiates an excitatory effect in the brain. And so 80% of our neurons in our brain are going to be GABA or glutamate. So it makes up a broad extent, the vast majority of the neurons, at least that we know of in the brain, are going to be GABA and glutamate. Of course, there are other, neurotransmitters. And there are other neurotransmitters as well, things like serotonin, dopamine, norepinephrine, acetylcholine. Those are going to be much more minor in terms of the pure number of receptors that are available in the brain. So when I think about alcohol use, when someone starts to use alcohol and they use it chronically, will they can experience some change in their homeostasis of the baseline, or the balance is probably a better way to say it, of these two different neurotransmitters. And so what your brain usually has a fairly even balance of excitation and inhibition at the same time. And this is and they kind of balance each other out when people aren't using alcohol. If someone acutely ingests alcohol, alcohol itself is going to increase that GABA activation, or that inhibitory activation, making your brain kind of slow down and stupor. It's kind of like what we see with people that get drunk. Stupor is the wrong word, but slow down and kind of just not thinking as well. And so individuals will, they seem to be more tired. They're not walking as well. They're having a lot of just effects of alcohol. And so in cases of acute intoxication, particularly for those who are not tolerant to alcohol, what we're seeing is just a heavier GABA presence in the brain versus glutamate. So you're tipping that scale to inhibitory. When someone drinks alcohol regularly and chronically, so over a period of time, the brain itself will fight against that excessive GABA that is being caused to be released by alcohol intake by internally upregulating or activating our glutamate receptor. So it's trying to get itself back to the balance, the seesaw, and the way it does that if you're drinking alcohol is to activate those glutamates. Withdrawal is kind of the flip balance state of intoxication. And so when someone has alcohol withdrawal, they had stopped or reduced their alcohol use significantly. And so all that extra GABA goes away, but you don't take away all that extra glutamate activity that your brain has activated over chronic use of alcohol. And so you get actually an excitatory, an overexcited brain, or when that leads to alcohol withdrawal, at least that's our understanding at this point in our science. And so alcohol withdrawal tends to be a agitated state where people are anxious and tremulous, and their heart rate goes up. Next slide, please. As I talked about before, neurochemistry wise, alcohol intoxication is just inhibitory in general. So it affects not only physical, but it affects the mind as well, of course. So people who are intoxicated on alcohol psychologically have a higher risk of being more inappropriate, whether that be sexually or physically aggressive. Their mood tends to fluctuate throughout, or it can fluctuate throughout their intoxication. So they may be kind of calm and chill one minute and then angry the next minute. So, and then of course, as we know, there's judgment impairment that occurs with alcohol, and that's due to effects of GABA in the part of the brain up front that helps you make good decisions. The braking system, as we call it, the judgment system gets impaired. And so people are more likely to do things they wouldn't do if they weren't intoxicated on alcohol. And then, of course, there are physical changes or physical symptoms of intoxication as well, and that progress generally as alcohol intake increases. So slurred speech, incoordination, and unsteady gait. So they have problems walking, they're wobbly. Nystagmus, which has to do with movements of your eyes, as well as impairment in your attention and memory. So you're not as attentive and you're not remembering things as well. As alcohol, you can get to the point of intoxication where you have complete absence of memory, called an alcohol blackout, or amnesia. You can get conjunctival injection as intoxication increases, and in extreme cases, you can get stupor and coma and even death. Alcohol intoxication is going to vary based on the amount of alcohol you drink, but most people's intoxication will relieve in around by 6 hours. Alcohol, as we talked about a few weeks ago, has this kind of zero order kinetic elimination. So the more you have in your body, the longer it takes to eliminate it. So people who have consumed higher amounts of alcohol are likely to have a longer intoxication period than those who haven't consumed less. Next slide, please. I think we saw this last week or the week before, or a couple weeks ago, I can't recall. when we were looking at laboratories. But these are alcohol intoxication levels that correlate with blood alcohol levels in an individual who is not used to drinking alcohol on a chronic regular basis. So this changes if you're a daily heavy consumer of alcohol. The numbers and these symptoms won't match up. So for instance, I've seen patients who are in the 200 to 300 milligram deciliter, where most of us would be kind of blacked out or can barely even talk, can sit and have a conversation with me because they've had time to build tolerance to that alcohol. And I won't read this again because we just looked at it last week. So, but it's there for your review. Next slide, please. Unfortunately, there's not an antidote per se for alcohol intoxication or alcohol overdose like what we have with opioids. And so it's really just a matter of you can't give a pill, you don't have a medication that'll fix it. It's a matter of just providing supportive care. And so we want to do anything we can to, if they're having problems breathing, to support that respiration and protect the airway from vomiting and aspiration, usually from vomiting. And so we're really just going to have to use means to help them keep breathing if in extreme cases of that. And that could get to the point where people end up on ventilation or mechanical ventilation in more extreme cases. Another concept to talk about is if you're in a medical situation and someone's been, if they come in with alcohol intoxication or they've been drinking alcohol, make sure you give them thiamine, IV thiamine if possible, prior to giving them a bunch of sugar or glucose. And we'll talk a little bit later about why this is, because it can affect your brain and cause cognitive issues, something that classically was called Wernicke-Korsakoff syndrome. But without giving the thiamine, which is often deficient in individuals who drink alcohol, you can get brain damage if you give glucose first or blood sugar first, essentially. Next slide, please. We're going to talk about withdrawal. This was just a recap. We already looked at this, but noticing that bottom state, we're going to again be focusing on a state in which our GABA balance is less activated because we've stopped drinking or we've stopped drinking as much. And then our brain is set in this hyperactive, excitatory glutamate-based state. Next slide, please. As I mentioned before, this is going to be kind of an agitated or hyperactive brain state. Alcohol withdrawal symptoms are various, and there are individuals who will have some of these symptoms on the slide and not others. But this time frame is generally going to be the time you want to watch for set symptoms, particularly as they get these time frames, as you get into more serious symptoms. So within as the alcohol clears their system, which is usually in the first 6-ish hours, as we talked about before. So usually between 6 and 8 hours, you start to get the early signs of alcohol withdrawal, the more common things we see clinically. And so we call autonomic hyperactivity. Their blood pressure tends to go up as well as their heart rate. They start to have this tremor, or the shakiness in their hand. Anxiety starts pretty early too, so they start to feel really, really nervous and on edge. And then you can also have nausea and vomiting as well as problems sleeping related to that kind of anxiety and hyperactive state. Within 8 to 12 hours after the last drink or the significant change in the amount of alcohol you're drinking, you can have what we call psychotic or perceptual symptoms. And so these, in that first 8 to 12 hours, they're not going to be accompanied by delirium generally or confusion states. It could be auditory or visual hallucinations. And in some individuals, they actually have some tactile hallucinations too during withdrawal, where they feel kind of itchy or like something's crawling on them. So you can see all those perceptual symptoms in some individuals. Again, not every individual will have every one of these symptoms. Within 12 to 24 hours is your highest seizure risk period. So really that half a day to 1 day period for people who will have seizures with alcohol withdrawal, this vast majority will have them start presenting at that time frame. And then there's this concept called delirium tremens, which is an old medical term. The DSM term is alcohol alcohol withdrawal delirium. They're synonymous, they're the same thing, but that usually occurs 20 after 24 hours. Most common time frame is the first 3 days, but it can occur even in individuals out to a week. Although I've never clinically seen someone post 1 week drinking have delirium, unless they were already in it before that week. I've seen people have it for once it started, proceed into a week, but I don't usually see a onset at 7 days. But the clinicians here can share their experiences with that as well. They may have, and this is just a graphical representation of what we said before. We're kind of looking at the different time frame and peaks of the different withdrawal symptoms that can occur. Next slide, please. All right, now that's just kind of setting this up for next week when we're going to talk about how to manage withdrawal. We're going to look at, how we change that GABA glutamate balance and how we can do that in different clinical settings. And so we'll look at inpatient alcohol detoxification, treatment of delirium, alcohol-induced alcohol withdrawal delirium, so the more severe aspect, as well as looking at, specifically, when can I manage alcohol withdrawal in an outpatient basis, and what people kind of fit into that framework of treatment. So most people won't, but there are some individuals you can successfully manage with daily outpatient